All right, so welcome everyone to the May CLaN. My name is Dr. Zoe Michaeleff and I'm the Research Operations Manager at Northern New South Wales Local Health District. And joining me today is Daniel Barry, who is a data analyst with Northern New South Wales Local Health District, and Dr. Alex Stevens, who is the Director of Research here at Northern New South Wales as well. And today, they'll be presenting publicly available health data, what it is, where it is, and how to use it. So we've got a great session lined up for you today. Before we get into today's session, I would just like to acknowledge the traditional custodians of the lands and waters where we work and live. We acknowledge the traditional custodians' living culture, their connection to country, and their contribution to the life of this region. We pay our respects to ancestors and elders of the region and to all Aboriginal people, past, present and future, and to any Aboriginal people joining us here today. So welcome. I'd like to give a huge shout out and thanks to our sponsor, the University Centre for Rural Health in the Northern Rivers, who is supporting the delivery and operations of our CLaN seminar. So a big thank you to UCRH. In case you're new to the CLaN, otherwise known as the Rural Research Collaborative Learning Network, this is a collaborative partnership comprising of 10 New South Wales local health districts, the New South Wales Health Education and Training Institute, the Tropical Australian Academic Health Centre, and 8 Queensland Hospital and Health Services and the Darling Downs Health and Innovation Research Collaborative. So the CLaN is a rurally led initiative that aims to provide high quality research, education and training to healthcare staff working in rural, regional and remote areas. And so our aim is to provide you with the education and training opportunities to build key skills in how to use and undertake research to improve the care that you deliver. So that's who we are. And in case you've missed any of the CLaN sessions this year or even last year, or you're keen to revisit any of the past presentations, you can do so by visiting our CLaN YouTube channel. And I'll pop the link to the CLaN YouTube channel into the chat shortly. Otherwise, if you just Google CLaN research, it should be one of the high hits that come up. So we're pretty easy to find, and make sure you go and have a look at what seminars have been delivered. There's some great content there to be seen. Because we're at the start of the session, just a bit of housekeeping. So given the large audience, we have muted your microphone, and please just make sure that you remain on mute throughout the session. If you don't wish to appear on the recording, please feel free to turn off your cameras. Otherwise, we're more than happy to see your smiling faces. We would love you to ask questions throughout the presentation today. If we can just direct you to put any questions into the chat function, Dan and Alex will stop periodically throughout to answer these questions. And if we've got time at the end, we'll open up for live questions to be answered at the end of the session. So as mentioned, it gives me great pleasure to introduce you now to Daniel Barry and to Dr. Alex Stevens. So Dan Barry is a data analyst working in the Northern New South Wales Local Health District Integrated Care and Allied Health Directorate. Daniel is a former graduate of the New South Wales Health Biostatistics Training Program and has worked on a range of projects in drug and alcohol, communicable diseases, environmental health, chronic disease and value-based healthcare. And Alex Stevens, we don't need to introduce Alex too much because he's usually the one at the start of these seminars giving the introductions, but Alex is the Director of Research at Northern New South Wales Local Health District. And in his role, he's got overall responsibility for the research ethics and governance operations, research development and support, and strategic engagement with the broader research ecosystem. He has a background in molecular biosciences, including a PhD, and biostatistics, and has research interests that interface between the two. And between these two guys, I could think of no one else better to deliver today's seminar on publicly available health data, what it is, where it is, and how to use it. Thank you, Dan and Alex. Over to you, Dan.
Thanks very much, Zoe. I'll just share my screen quickly, so bear with me. Okay, so today we've got our presentation around publicly available health data, and I guess what we're kind of meaning by that is the data that might be able to be made available to health researchers, whether it's open or restricted. What we're kind of hoping that you get out of this presentation is an understanding of the health data lifecycle, an understanding of the differences between open and restricted data, how restricted data can be accessed for research, and how ethics approvals fit into this process, an understanding of what data linkage is and where public health registers might be able to support research instead of customised research linkages, access to some resources that help you to find data sources and subject matter expertise, and some simple pragmatic considerations for using data in research. Now, covering a topic as broad as this in under an hour means that there's not much time to get into depth, so I'll be going a mile wide and an inch deep on this. What we're hoping to provide is a helicopter tour of the data that can be available to researchers, how to access it, online resources, and an approach to access and use of other data for research. Now, a lot of this is fairly New South Wales focused, and I'm aware that there may be some people from other jurisdictions in the room, but I think some of the overarching information is fairly consistent across states. It'll just be the specifics about our particular resources that isn't. So we've kind of broken this down into 4 sections. The first section is kind of how health data is created. The second section is on open and restricted data. The third is on data access and ethics. And the last section is on data linkage. So I'll start off with a couple of quotes. And the first quote gets mentioned a few times, but where I pulled it from is a book called Bad Science by Ben Goldacre. And the second quote is from Jeff Bezos of Amazon. And I start with this because research involves advancing the understanding of a field, generally by refuting or confirming a hypothesis. And to do this, you need observations, you need data. But if the data isn't of sufficient quality, then inferences made from it aren't trustworthy. And one way that might show is when conclusions from the data don't align with your individual experiences. Data can't be good quality unless it's created in the right way. And the quote from Jeff Bezos was followed by a little bit more about that with his thoughts as to why he thinks that the anecdotes are usually right, which is usually that the data collection and management has gone awry. So having high quality health data available for research isn't just a matter of having the processes in place to access and analyse the data, although those are important. Having and maintaining high quality health data requires an organisational commitment. It needs considered processes and sufficient resources to support the system's design, maintenance and usability. With these in place, you can get data entered into a system that supports useful data structures, have quality processes in place to detect and rectify anomalies in the data, and have all of that stored on a system that's as easy to use as possible. Now you might ask, why does that matter for research? Well, the data's only as good as the process used to generate it, and well-intentioned, methodologically reasonable research based on poor quality data does get completed, and in health that can form part of the evidence base for practice. In a worst case scenario, that can cause harm, especially when you're making decisions around subjects like clinical process or service continuity based on that evidence. To answer research questions, you need to have data entered somewhere in the first place. And generally, the data that we're gathering is gathered for the clinical management of a patient, and that's considered the primary purpose of use for the data. The importance of this is the primary purpose of use for the data legally justifies the collection. It's also important because the systems used to collect the data will generally be designed and implemented from a clinical use perspective. And so things like how the forms appear in an electronic system to a clinician influence how data is captured. And so an example of that might be if there's a field on screen that occupies useful screen real estate, but isn't frequently used, then that'll occasionally get co-opted for another use by pragmatic clinicians. It's also important because the system for collecting the data might not be designed with a view to making data useful for other purposes, including research. So this means that making data available for research generally requires additional work. So the kind of flow diagram here shows a bit of a life cycle of clinical data, with the aspects related to the primary use in blue and the aspects related to the secondary use in orange. The system where the data is entered is often referred to as a source system. On entry, there's generally some data quality rules applied to the entered data to ensure that it has sufficient quality to be useful clinically. The source system will generally facilitate views of patient data structured in a way that's useful for clinicians. The data may also be used for other reasons. So it might be things like quality management, activity reporting, demand forecasting, and also research are all considered secondary uses for the data. That language around primary purpose and secondary purpose is written into the legislation that governs how the confidential health data of our patients can be used. There's generally some sort of process designed to create consistency within the data by processing, transforming, and combining data into a data asset that then can be used for secondary purposes. Bless you. Shown here, I've got a bit of a diagram about how the source systems for data gathering might be arranged within a health service. So it's not necessarily accurate, and it's a simplification, but it's just meant to be a kind of conceptual model. So this doesn't include kind of administrative systems that might exist to manage non-clinical components of a health service, things like workforce payroll or corporate systems. It's just the clinical part. But most health services will operate clinical information systems according to a model that's similar to this diagram. There's a central EMR system that provides capacity to capture the data across a range of care aspects, and the components within that system are all integrated with each other. There might also be a range of other systems that provide the capacity to capture data in specific care domains, and these may be integrated with the main EMR, or they might not. There's a lot of variability in this when you look at different jurisdictions. So for health districts in kind of New South Wales, there's 15 districts, a couple of specialty networks, and an affiliated organisation, each with unique aspects to their clinical data capture. So you might ask, why not have it all in the one EMR? And historically, it's because a particular piece of software external to the EMR might meet needs better. At the time of development or implementation, the EMR might not have had capacity to provide the information. And also there's sometimes particular data domains that might be managed by different organisations. So an example for New South Wales is public pathology is managed by New South Wales Health Pathology. And so there's some integration that needs to be done between that and the local health districts to utilise the data. So data from the source systems is frequently supplied to support secondary reporting for purposes such as clinical quality, safety, activity reporting, forecasting, performance monitoring, etc. This occurs at multiple organisational levels, so it occurs at facility level, district level, state, national levels. In order to do this data needs to be standardised, and the extent to which it needs to be standardised increases as you make the organisational level broader. So if you're reporting something at the national level, the kind of question that you're contending with is how to assemble data from potentially every health service in the country and make it consistent. And the only way to do that is to ensure that the data that you receive is standardized so that each of your individual data sources supply data with a consistent structure and definition. The data from these various sources then needs to be assembled in a way so that it can be interrogated to be used, whilst also kind of managing considerations such as data security and legal requirements. What this means in practice is that data from a particular source might end up in a whole range of secondary data assets, each designed for a particular purpose and supporting different uses. And this creates a trade-off, and that trade-off is that as you get the broader view, you lose some of the detail from the data. The reason for this is it takes technical resources to standardize the data. And so organizations that need standardized data tend to ask for the smallest number of data points that they can reasonably use to answer their questions, and then only standardize that minimum data set. So what's the benefit of knowing this? Why do we care? Well, ultimately, understanding how data used for research is created leads to better research. I've mentioned that it's possible to conduct research that's methodologically sound on data that appears to be good quality. To safeguard against that, really you want to have people who are involved who understand how the data is created and also can provide feedback and knowledge to those who are generating the data and the custodians of research data. And so in a lot of scenarios, one of the conditions for accessing particular data assets is that any anomalies within the data are reported back to those data custodians. And I might just pause there for a second, Zoe, to see if we've got any questions. Excellent, I'll move on.
Sorry, Dan, just one question popped up. Do you ever factor in budget and dollars during this phase? Or where do you add this to the business case?
I might take that one on notice, Zoe, and come back to that later on.
Excellent. And any consideration around cultural, such as Aboriginal, Torres Strait Islander involving peoples, or ethical issues?
And I might leave that because I think that might be answered a little bit further down the line, but certainly there would be.
Thanks, Dan.
All right. So I'll talk a little bit about open data and restricted data. And open data is pretty much what it says on the packet. It's data that anyone can use and share. The only caveat around the use of open data is generally citation, attribution, recognition. It's typically aggregated data, and the documentation quality for open data can be mixed. That can be a bit of a challenge in using it. It's typically supplied in formats that are fairly easy to interact with, and it's less likely to require more specialised skills to interpret. Australian governments generally have a commitment to supplying open data. So in New South Wales, agencies need to open their data in a format that can be readily used. Data will be made available to the people of New South Wales whilst respecting the privacy and confidentiality of those to whom the data relates. And that's from the New South Wales Information and Privacy Commission. And there's a range of sources of open health data that can be used to support research. This is a list of a few of those sources, and I won't go into all of them. The links within the presentation, as well as a resource that we'll send around after a presentation, allow you to kind of visit those at your leisure. And they provide a range of open data resources that report to various levels of granularity and across different jurisdictions. Some institutions provide similar data in multiple places, which can get confusing at times. So Queensland Health, New South Wales Health, the Australian Institute of Health and Welfare, the Australian Bureau of Statistics and Services Australia all provide public-facing open data or reports. In the Services Australia case, they provide this in the form of pharmaceutical benefits schedule and Medicare statistics. And we'll look at a quick example of how one of those can be used in a moment's time. Talking about how open data can support research, open data on its own can be sufficient to support the publication of research, and there are health researchers who are fairly expert in using this data to support their research, and I think kind of the key part of their expertise is they understand exactly what they can access freely, but they also understand quite well the kind of questions that open data is likely to be able to answer. And I guess some examples of those questions are situations like policy changes. So the example I've got here is a change to an MBS co-payment for a particular service might change the balance of patients seeking that form of care in the public health system versus general practice. And that might be the kind of thing that you can see through open data sources. For other research questions, while open data might not support a complete answer of your question, it can still be fairly insightful. So you may be able to find information in open data that causes you to reconsider your hypothesis, such as a policy change or a coding change. You may find information that helps you to frame your research question in more definitive terms. You might also be able to trace back to other data sources and areas of subject matter expertise that help you progress your research. And I guess lastly, there's also quite often in open data, there's information that's complementary to the kind of work that you do in health research, and that's thinking of things like population data from the census. So at the risk of this all going south, I'm going to try and do a bit of a demo of how you might look into open data to answer some of these questions, and I'm going to use Health Stats New South Wales to do that. And what I kind of hope to show is that with a small amount of effort, I can find a data source for a given topic, some subject matter experts, and some cohort definitions. So wish me luck. So you should all be able to see the New South Wales Health open data site here now. And on this, you have information on a range of topics, as well as a few additional open data platforms that New South Wales Health manages. One of these is Health Stats New South Wales, which contains information on a whole range of population health indicators. And the one I'm going to look at here is drug-induced and drug-related deaths. So Health Stats provides some information that you can download on this, and it also provides kind of a graphical interface to pick out what you want. I'm just going to quickly look at total deaths and look at that split by regional and metropolitan LHDs. And so with this, you can see there's data with an interesting feature in that it seems to be divergent in the latter half of the data, but also the sources provided. So if you're looking into this, you can see that cause of death data here can be provided from the Australian Cause of Coordinating Registry Cause of Death Unit record file. You can also see that it's kind of held on Safari, and that the expertise on it is within the Centre of Epidemiology and Evidence within the New South Wales Ministry of Health. And you can see how the denominators for the calculations were generated. Additionally, these sites tend to provide some technical details, and those technical details help you to look at things like how the cohort is actually defined. And I'm hoping this gets us to that resource. So without requiring kind of a lot of effort, we've been able to get to what the data source is that can kind of inform us on the topic a little bit more, some other people that we can talk to, and the ways in which the Health Stats New South Wales folks actually define this so that we can potentially mirror that. I'll get rid of all that and go back to the presentation. I'll move on now to talking kind of about restricted data and kind of what we're considering as restricted data within this context is data sources or assets held by health organisations, but where access and use requires approval, and sometimes that's especially the case for research. And that might be restricted by law, might be restricted by ethics, and there'll be a little bit more on both of those later. This is typically the case for unit record data, but it's also the case for aggregated data in certain circumstances. And just to provide a definition there, when I'm saying unit record data, I mean that data which is kept and relates to single instances of a patient attending a health service. Generally, aggregated data sources and tools that can be used to support research are designed to be a little bit easier to access and extract and use, and that's a pretty sweeping statement. Unit record data, however, will often require access to some specialized skills or training in order to access, extract it, and use it. There's certain types of data that might be subject to specific legislative or policy protection, and three kind of examples that I could think of for this presentation were data around HIV, data around child protection, and data around sexually transmitted diseases. For certain data sources, the projects that you want to use the data source for might require registration with the data custodian, and that data custodian may follow up on kind of projects and access, and the data source for the health stats example on drug-induced deaths is one of those. It also includes linked data, and we'll talk a little bit more about linked data and public health registers at the end of this presentation. And I'll just also kind of make the point that clinicians may have access to all of the data that is required to answer research questions via the EMR, but constructing research data sets from that data can be onerous and can have a fairly challenging approval process. So using and accessing restricted data for research, and I'll shift over to Alex fairly shortly to look at this in a little bit more depth, but we're all fairly familiar with instructions that are challenging to interpret, and the legislation and policy governing the access and use of restricted data assets can be fairly difficult to unpick. However, most health services will have a dedicated research unit who will be able to provide advice on that. The administrators of restricted data assets will have subject matter experts who can help with questions around which research questions certain data assets may be able to answer, and local users and data asset communities of practice are in place for a lot of data assets, and they're usually fairly generous with their learnings and expertise. So again, this is not a exhaustive list of restricted data sources. This is probably more so a list of a few that are particularly pertinent to research. So Safari is it stands for the Secure Analytics Platform for Population Health Research Intelligence. It's a statewide New South Wales health analytics platform that hosts a range of data assets, and it's managed by the Centre for Epidemiology and Evidence within the Ministry of Health. Their website provides information on the data they hold and how to access it, and it's a really useful resource for a range of statewide data for research. And I'll try quickly to do another quick demo of what the Safari portal shows and the information that it has. So if you look on the Safari portal, and the links that we have within this, again, they'll be supplied after the presentation, you can see the data assets that are available. The individual pages for these data assets give you a fair bit of detail about the data asset itself and how you can use it. And in particular, what I just want to quickly show people here is they provide you the legal basis. So I've clicked through to the site for the perinatal data collection, and that shows that it's established under the Public Health Act, that there's a policy directive around data collection and reporting for this data asset. And it also shows you the use purposes for the data asset. And then you can also find contacts, which I won't dig into right now, but also the ability to access the data asset on the one website. So it's a good place to look at to get access to a range of data assets at once and see what they hold, what they can be used for, and how you can access them. One kind of caveat there is that the data assets on Safari hold unit record data, and they do require some skills and training to extract and work with, just because of the way they are held on the secure analytics platform. I'll also talk a little bit about Lumos, which is a fairly unique data asset that holds unit record GP data in addition to public health service data. And that kind of access and linkage of GP data is something that doesn't exist anywhere else within certainly the New South Wales health kind of data ecosystem. And the last kind of source of data that I'll talk about is QIDS, which is the quality improvement data system. And people are probably more familiar with this than with the other two. It's restricted access, but it's an aggregated data tool that's fairly broadly accessible. It allows users to develop a range of data tables and graphics, and extends mostly for quality improvement, but there are other allowable kind of uses for the data, including research. It's something that's incredibly useful, and I think one of the benefits of it is it requires a lower technical overhead to use, as well as its kind of broader accessibility. The last couple of links on this slide are for the statewide data asset register and for the health information resources directory. So those two sites are the most kind of comprehensive collections of information about data within New South Wales Health. The statewide data asset register is comprehensively kind of lists all of the data assets held by New South Wales Health, while the health information resource directory contains a lot of information about data. And where it's kind of particularly useful, I expect, for research is it provides information about the variables that are used within individual data assets. So I'll pause there for a second, Zoe, and hand over to Alex to talk about research ethics and data access.
Sounds good. Thank you very much, Dan and Zoe. So just bear with me. I'm going to steal Dan's presentation and share my screen. Good. So hopefully that's come through. Okay. So unfortunately, this is probably the dry part of the presentation, but it is a necessary evil. We're going to focus a little bit on, the ethical and scientific group aspects of, obtaining access and using data, and a little bit about the governance. So Dan's touched on this a little bit. We've taken the lens of research for this particular presentation, but accessing and using personal health information can be done for a variety of purposes in addition to research. I've noted here the management of health services, training and education. And the reason why I'm mentioning that is, the regulatory and authorizing environment to be able to access and use that data tends to try to couple all of the processes for any number of those reasons. And so there's a certain level of commonality in terms of what you need to do to access that data, those variety of purposes. So Dan's covered off on this. I'm not really going to cover it. I'm not going to go into too much detail, but it's basically the data is kind of broken into two main ways that you can access it. So the publicly available or open data, as Dan's described, or there's the data held by organizations, which is the restricted data. And that's kind of the view that we're going to take for this section of the presentation. There is data held by other organisations, as Dan mentioned, such as the ABS or the Australian Institute of Health and Welfare. They are likely to have descriptions of their own processes for being able to go through and navigate the hoops to try and get access to that data. So we're going to focus more on data held by organisations. This slide's very busy. We're not going to test anyone on this, but it's just to describe that the regulatory or the authorizing environment for being able to access and use unit record data is fairly well developed. It's based on legislation, key guiding documentation, and operationalization through policy. A couple of key ones is, for example, the Health Records and Information Privacy Act, the National Statement on Ethical Conduct in Human Research, a national document. We've got some New South Wales specific ones around, guidance and policy. The lens, and Dan's already mentioned it, is from New South Wales. We haven't gone to the lengths of trying to figure out what it is in the other jurisdictions because you can see it's fairly well involved. But we think that the main concepts or the key messages should be the same or very similar. So each state or jurisdiction will have privacy legislation, the national statements of your national document, and there may or may not be additional guiding documentation that operationalizes the instructions. What we're going to do for the rest of my section of the talk is focus on two main aspects relating to the permissions to access and use personal health information and also the authority to disclose. Those two concepts are coupled to a certain degree, but they're distinct. So hopefully by the end of this, we'll cover off what provides the permission to use data, what provides the authority to disclose data, what are the conditions associated with that access and the disclosure. We're going to do it through the lens of unit record data, and we're not really covering off on the special case of accessing aggregate data, because often that's publicly available or open access, or if it's not, it really does mirror the processes that we're going to talk about for accessing unit record data. So focusing on the permissions to use or access and use personal information, I find it's really handy to go through the legislation. So in New South Wales with Health Records and Information Privacy Act, it's got a really handy statutory guideline for research, and you can kind of follow that systematically to understand what can provide you the permission to access and use data. So the first step is, if you can use data that's de-identified, then the legislation provides you the permission, right? If not, then you can keep working through the guideline and go to the next step, which has consent being provided. So for example, might be a research study, the participants have provide the data, provided consent to use the data, well, then you can do so. The next two here was data collected for the primary purpose, or was the proposed research directly related to the primary purpose? In my mind, for research, they kind of piggyback on a research study. So invariably, it probably would involve an element of consent from those that participate. So then the permission's linked, I guess, to that consent process. The next one is the disclosure use related to any applicable laws and some certain circumstances, and Dan nicely described it. We've got some provisions in the law that would allow us to establish a data collection, and that typically encompasses the permissions to do so. And then if all else fails, there's actually a research exemption category in the legislation that would allow you to use the information or the data without consent, without de-identifying it, but you've got to jump through a few hoops. Jumping through those few hoops is actually obtained through this ethical and scientific review process. So there's a direct interrelationship between the way you can access or the permissions you can receive to use that data and the ethical oversight. So hypothetically, for example, if you're proposing to de-identify the data, that would often be accompanied by the submission of a low-risk ethics application. In fact, that links to section 5.1.7 of the national statement. The next three there fall into a broad category of really you're obtaining consent to use that data for research purposes. That could be a low-risk or high-risk research project. The legislation typically would cover off on the permission, so grade that one out. And then the last category there, if you don't satisfy any of the previous conditions, you can still use the identifiable unit record data, but essentially that constitutes a high-risk ethics application because it's a waiver of consent. So there are a number of requirements that you would need to follow to do that. In terms of the authority to disclose the data is slightly different in concept to the permission but in some cases coupled. So in terms of this broad category here, which I've lumped together of, research study, you've obtained consent. The consent couples the permission and the authority to disclose. If you're not getting explicit consent and you're proposing to use the data through some applicable law, well, then the authority to disclose should be integrated within that legislation. The other two categories would rely on somebody probably within your organization that has the authority to disclose that information on behalf of the organization. So as a rule, typical rule in New South Wales Health Organisation is the identified data can be disclosed by a senior manager that typically occupies an executive level position. The disclosure of unit record data that's identifiable is typically rests with the chief executive of the organisation. Just very briefly, once you've navigated through the permissions of being able to access and use data and then the authority to disclose, the disclosure of the data and then accessing is typically accompanied by a number of conditions, right? And these conditions may involve undertakings, specification of precisely the data that is disclosed. It might cover off on elements such as data storage, security, confidentiality, access, maybe other relevant conditions and data governance clauses. And occasionally, these conditions might be formalized in a data transfer agreement or potentially in a data management plan. And this is my last slide, so hopefully I haven't put you to sleep. There's a lot that goes on the back of trying to understand what are the rules and processes and the approvals that you need to access, use, and also disclose data. And we don't expect people basically to remember this at any one time, but there should be people, hopefully, that you can make inquiries to or readily access that should know this. And one of these is typically the research office should be knowledgeable in those processes. So likely your best bet in terms of providing jurisdiction-specific advice, or the data custodians of those individual data collections are also good people to potentially contact to understand how to access their various data collections. So that's the end of my section. I'm going to hand back to Dan to go through the final part of his presentation. Thank you, Dan.
Thanks, Alex. Bear with me. Okay, so the last part of the presentation is on data linkage, and then we'll summarize and recap. And this is fairly short. We haven't gone into much depth here. So what is data linkage? Who does it, and how is it done? Data linkage is essentially combining data from different sources that relates to the same entity to create a richer data set. And for health data linkage, that entity is usually a person, but occasionally it might be a family, and there are some instances where it's a location. Health data linkage is generally managed by a specialised unit in a given jurisdiction. In New South Wales, it's managed by the Centre for Health Record Linkage. It's also called the Cheryl. In Queensland, it's managed by the Statistical Analysis and Linkage Unit, which is also called Data Linkage Queensland. And nationally, it's managed by the AIHW Data Integration Services Centre. Links are attached to kind of each of those data linkage groups that we've mentioned. And in addition to information about linkage, the Cheryl website is another excellent resource for information about data, because they hold a lot of data dictionaries for the data assets that they use commonly for linkage in New South Wales. 2 lines is probably insufficient to kind of describe data linkage, but at kind of the highest level, what data linkage does is uses matching algorithms which run over identifying information in order to determine whether records belong to the same entity or not. that requires the identifying information, and consequently there's a fair bit of risk in terms of privacy and confidentiality. And so to limit that, the personal information, the identifying data, is separated from the health service interaction data, which the Cheryl would call the content data. The linkage process occurs on the identifying data, and then the identifying data and the content data are recombined after de-identification. One kind of other point about the linkage process is that it can be a fairly substantial process. So it requires a lot of computational power. There's a significant demand on data linkage services, and there are fairly extensive administrative and clerical requirements, both in order to get linkage approved, but also that need to occur within a linkage unit to ensure that the data supplied via linkage is of good enough quality to use. Kind of when and why you might use data linkage, to me almost seem like the same question, but it's there's kind of two similar kind of questions that are typically answered using data linkage. So questions about kind of patient journeys and care that spans multiple care settings. So that might be things like, does an intervention during patient transport decrease length of admitted patient stay? And then the kind of second version of question is answering questions where health service interaction might have an effect on an indicator outside of that health service, and data from outside the health service is required to measure that. And so that might be things like, does a perinatal intervention affect a NAPLAN score? So data linkage is, as far as I know, kind of the only way. I think it's legislated that that's the only way to attach non-health records to health information. There's also two types broadly of linked data assets that are created by data linkage units. The first is statutory linked data collection. So in New South Wales, we call these public health registers for the most part. And the second is research linked data assets. So the statutory linked data collections are legislated data assets that health departments are required to generate and update. They're generally associated with a particular legal use case. So it might be something like epidemiology of particular diseases. And they can be accessed by those whose needs fit that use case with fairly minimal cost. They're created by the linkage units because they're required to by law, and so they're business as usual for linkage units. Whereas research linked data assets are developed to answer specific research questions, and they're created by linkage units as a service. And the distinction there is that typically means they have a cost and they kind of run that somewhat as a business. They require different approvals from ethics committee and data custodians to be in place for the linkage to occur. They can only be accessed by nominated researchers, and they're subject to specific and fairly stringent conditions. They're also not, I mean, this goes for any linkage data asset, but they're not easily changed. And the risk with, one of the risks in research data linkage is you don't get a variable that you need, or the linkage approach is different or doesn't yield the results you expect. And when that happens, that can be a do-over. So that approach needs to be carefully thought out. The other aspect of this is because they're not BAU, you have to start from the beginning of the approvals process, and there's quite some time before you're looking at your actual data. Whereas if you look at a statutory data collection, it's probably already available. Why am I talking about this and going into so much detail? Well, it's because the statutory linked data collections can be used for research under the right conditions. So when the research fits the legal use case for the statutory data collection, and where the statutory data collection contains sufficient data to answer the research questions. In New South Wales, the majority of the statutory linked data collections are hosted via Safari. And in the same way that you could access, that I showed the quick demonstration on the perinatal data collection, you'll see some of the register data on Safari, and you can find the legal basis for use, the data sources that are linked together, and how to access those. So in summary and to recap, so we've covered off kind of aspects of the creation of health data. We've covered off the difference between open data and restricted data, where you can locate sources of both and where you can locate more information about both. We've covered off how access to restricted data is governed and how ethical approval fits into this. And we've talked briefly about what data linkage is and how you can find more out about linked data. And we've got one more slide to go. And that slide is a very kind of high level pragmatic approach to using data to support research. The first part is kind of wherever possible, and it obviously isn't always possible, but have a team with clinical, academic and data analytics expertise, or be able to draw upon these, and people get pretty creative in terms of the partnerships that they develop in order to do that. Approach using your data sources using a hierarchy that investigates the simplest, most accessible data sources first. So you may have a research question that you think warrants the use of more detailed, difficult to access data straight up. I guess what I would argue there is if you look through open data and then move towards aggregated data sources and then unlinked restricted data and then the statutory data collections, and then settle on the fact that yes, you absolutely need to undertake a research linkage, you'll spend a bit of time doing that. But if you decide that that's the only way to do it and you haven't looked through those other data sources and they could potentially answer your question, you'll spend a lot more time going through that process to develop a customized linkage. And so I think looking at the open data first to kind of help with context and moving through things in that way is in general a more efficient way to kind of approach your data needs. And I think that's pretty much it then, Alex. So I'll finish up and I'll say thanks to everyone for your time, and thank you to Zoe and the CLaN organisers as well as all of the attendees. And I'll hand back to Zoe for questions and info about the next seminar.
Thank you so much, Dan, and thank you, Alex, for a true whirlwind tour of data and publicly available sources, but it was hugely informative. Well, we're just waiting for some questions to come in. I just thought I'd announce and advertise the next seminar in June, where we're going to take a dive into qualitative research. And this session is going to be led by Associate Professor Di Redling, who's the head of program at Bond University, and Dr. Kate Odgers-Jewell, a conjoint academic with both Bond and Northern New South Wales. So please, registrations are open now. The link, I've just popped that in the chat. Jump on early and we'll be notified about that in the coming weeks as well. And lastly, we always would appreciate if you could take a couple of minutes to complete the evaluation survey for today's session. We're always looking at improving what we're doing and how we're doing it. So we welcome all suggestions and constructive criticism, just so that we can keep delivering high quality and relevant seminars to you. Can I open up to any questions? Nothing's come through recently. If you'd like to come off mute and ask a question, please feel free. We have a couple of minutes left. Just scrolling through the chat. I think there's been a lot of good collaboration in the chat too. So thank you for everyone who's responded to questions. It looks like Dan and Alex, you've given people lots to think about. I think you've given everyone ample opportunities to ask questions. If you do have any questions, please feel free to reach out to us and we can direct them either to Dan or Alex. And I might bring today's session to a close. So thank you again, Dan and Alex, for your time. Thank you everyone for attending, and we look forward to seeing you at the June seminar, where we'll take a dive into qualitative research. Thanks again, everyone.
Thanks a lot, everyone.